Okay, our next speaker, talk title, Congenital Heart Defects and CTNNB1 Syndrome and Raising Clinical Awareness. Please welcome Dr. Lorenzo Sinibaldi, clinical geneticist, Bambino Gesu Children's Research Hospital. Was he in here, Shpila?
Yes, I am here. Can you
he's
hear
on
me?
there. Thanks, okay.
Can you hear me? Hello? Can you hear me?
Hello, we hear you, yes.
Yes, thank you. Just a moment, I will charge my presentation. Can you see the presentation?
We can see it, yes.
Okay, so thank you for your introduction, and I would like to thank Dr. Stella Mirosevic for this invitation. I'm very sad I can't be there in Ljubljana with you, and I'm very emotional to speak to this audience of very sensitive persons and very involved in this in the management of this syndrome. So as you said, I'm a clinical geneticist, so I'm not going to go through the molecular details, but I'm going to focus on this aspect that is still quite neglected. And I don't know if in the future there will be other papers like saying that the heart is important in the management. The heart controls are also important in the management of the syndrome. So I'm not going through this going to do through this very quickly, as we all know that the CTNNB1 gene is responsible for the syndrome, is an autosomal dominant disorder, and it especially gives global development delay, impaired intellectual development, and axial hypotonia, peculiar craniofacial features, microcephaly, spasticity, and visual abnormalities, as we all know. You already have been told a lot about beta-catenin, which is the protein which is encoded by CTNNB1. It is actually on chromosome 3, the short arm, and as you see, is on the band 3p22.1. This is the protein that we already saw during this during the Congress, and we all know that the protein has got this sort of armadillo structure, and this is the structure in this cartoon, and this is the ligand binding site, as you see. And as we know, beta-catenin is a very polyedric and multi-talented, I would say, protein. It's got many ligands linking to this binding site, and it's important in transcription factor. So you know that when the WNT signal is off, beta-catenin is not active, it's degraded through this proteasome machinery. When the WNT1T on pathway is on, the beta-catenin is free to do its work and go through to the nucleus and link to TCF and LEF transcription factors to start the reading of many target genes. It's important that we know that the pathway of the beta-catenin is very important for cell polarity, which is very important for what I will later say, which is the heart development. So we know that this is a sort of summary of which are the WNT1 beta-catenin pathway linked to non-cancer disease. We have, of course, the nervous system, which has been told a lot during this Congress, but we also have the heart. So the heart is beta-catenin is very active on heart development, and is already been linked to atherosclerosis, arrhythmic cardiomyopathy, myocardial infarction, cardiac fibrosis. Very few is known about congenital heart disease, even though if we know that beta-catenin is active in heart formation. So, for example, brain. We know that beta-catenin is very active. The brain is expressed there, and we know that, you see here, is expressed in the large amounts of protein which are active in brain. Is involved in a different phase of central nervous system development. And for example, here I just put these cartoons about the hippocampal development, and through the activation of WNT1 pathway, the cyclin D1 and NGN2 and NeuroD1 factors are activated. And this also is a cartoon about what we know, summarizing what we know about the action of direct action of beta-catenin in a nervous system, and also when it's inhibited, it also leads to other action. But in the last few years, let's say last 10 years, a few other in the involvement of a few other organs in which beta-catenin is important have been studied. For example, the craniofacial anomalies, which are involved in specific beta-catenin pathogenic variants, and they have been studied in humans and in mouse model. So we also know that beta-catenin is very important for the syndromic characteristic somatic features that we can observe in our patients. You will be probably hear about this more when Dr. Walter Tucci will do his presentation later on. But let's start talking about heart. Heart is this red rectangle here, and it shows the expression of beta-catenin in heart, which is important. As you see, it's a high expression. And this is another photographs I show you to show the expression of the CTNNB1 gene in heart in different kind of cells, for example, myocytes, fibroblasts, endothelial cells, and in different age of the of these samples. So it's actually beta-catenin is active not only during embryonic, fetal, and the first stage of our lives, but also during the adult life. And this is also a sort of cartoon explaining how many factors are important in the cardiac development. And especially here in this green rectangle, you see the CTNNB1. CTNNB1 is very important for the second heart field formation that will go through the formation of the right ventricles and all this part here of the heart. So this is all things that we knew. And before doing this clinical study, we actually were asking why CTNNB1 is so active in the heart formation, but we don't observe any heart disorder in the patients, or very rarely. So this is what we know is better I would say described in literature, the beta-catenin signal transduction in atherosclerosis, myocardial infarction, arrhythmia, cardiac fibrosis. Very few we know about the morphological aspects of hearts designed by the WNT1 beta-catenin transduction signal. So, for example, in this summarizing cartoon, I show you that here we have the action of beta-catenin, and also beta-catenin instead is blocked here. The expression of the signal, transduction signal, is blocked here, and it's here again. So it's important for this mesoderm formation And in a second phase, it's important for the cardiomyocyte progenitor proliferation. So this is all things that we know from the literature and have been already demonstrated. So we started from this observation that CTNNB1 is highly expressed in the heart. The function in the heart is documented, and we actually have on and off description of heart defects which have been occasionally been reported in cohorts of patients or single case reports, and they were all linked to loss of function variants. So we observed that actually no study specifically going through the heart defects has been produced, and we decided to start studying the heart function in the cohort of patients we are following in our hospital. So this is the cohort of patients we studied 19 patients, and with CTNNB1 pathogenic variants. 8 were females, 11 males. And this is the main age, which is 10.3 plus minus 6 years, going through 3.6 years to 23 years old patients. These are 2 of the girls which are part of this cohort. And as you see, we can see some of the features that have been already described, such as microcephaly, an elongated face. I always observe these almond-shaped eyes and a bulbous tip of the nose, quite long nose, and thin upper lip, large auricles. And this is the clinical characteristics of our cohort. So we observed that, generally speaking, the short stature was quite common. Microcephaly or a relative microcephaly could be described. And about the neurodevelopmental issues, we always observed neurodevelopmental delay, intellectual disability, speech delay, and motor delay. They were always present. They are also an important part of behavioral issues, which are like ADHD, autistic features, and sleep disturbances. Here you see the motor aspects of our cohort of patients, and limb spasticity is very often described, and also an ataxic gait, dystonia. And these are the visual defects. Actually, we didn't ever find any FEVR, so no retinal problems until now. And we often found strabismus and astigmatism. And these are other clinical aspects that we found. Scoliosis was quite often described, and sometimes MRI brain anomalies were also found. But what surprised us during this study was the congenital heart defect presentation, which was 5 on 19 patients, designing a 26% percentage of heart defects in the present cohort. So we decided to go through literature, and we designed a literature review using the Boolean operator or and using the beta-catenin and heart or cardiac or congenital heart disease or congenital heart defect or defects, and using also CTNNB1 with the same terms. What we found was not so much. We just found 6 articles reporting congenital heart defects in patients with CTNNB1 syndrome. Many of them were already included in this report by Kayumi et al. published in 2022. We have to say that this heart defects weren't reported in the main article, but of course in the material, supplementary material, the supplementary clinical materials. So you really have to look for it in details because it's not easy to find them at the first look. So we consider only 120 of these patients in the paper by Kayumi et al. Because they were the only one who have an adequate phenotype description. So we found that overall tetralogy of Fallot, Bales anomaly, and septal defects were reported. There's also another paper where was published even before 2022, in 2020, by Morton et al., in which they decided to look for damaging variants in cancer risk genes. So CTNNB1 was included, and they found 3 cases affected by heart defects. But we have to say that these 3 cases weren't described at all. Just the heart defects was cited. That we didn't have the sex or any other clinical description. So this is the percentage that we could elaborate from our literature review. Generally speaking, 8.3% of patients in literature, in case reported in literature, show an associated heart effect, which is not very low percentage, since you think that the incidence of cardiac defect is in general population 1 on 120. So 8.3% is quite high. As a result, in this in our study, we reported pathogenic-like variants, and they were all reported according to ACMG guidelines. We had 9 novel previously unreported variation, which were so the 47% of the entire sample. In 4 individuals, we having heart anomalies. The variations were new, never reported, were novel. And so if we considered only the severe cardiac malformation like absent pulmonary veils, tetralogy of Fallot, or atrioventricular canal, then we arrived to a prevalence which is about 15%. If we consider all the heart effects, we arrive, as I said before, to 26% of prevalence. So this is a cartoon explaining the same that I tell in the present slide. We studied the heart effects through chest X-ray, electrocardiogram, 2-dimensional, and color Doppler echocardiography in all the patients. This is the kind of heart effects that we found. As I said before, absent pulmonary veil, which is very, very rare heart effects, especially with intact ventricular septum and with patent ductal arteriosus. Especially this association was previously described in this syndrome, which is a very rare chromosomal syndrome. Then we have mitral valve prolapse with moderate insufficiency. This was showed in one case. And then we have atrioventricular canal and tetralogy of Fallot and another mitral valve prolapse. So we have two mitral valve prolapse described in this cohort. This is a summarizing table where you can find in bold all the reported case in our cohort, and the other are all the reported cases in literature, which are 18 in total. If we do an observation of the total of these total cases, 18 cases, we can see that the etiology of Fallot, receptacle defects, and pulmonary valve anomalies are the prevalent cardiopathy. Then we can say that it seems that males are more frequently and more severely affected compared to females, even if we only have the sex of 13 patients. The other 5, the sex was not provided. All the variants were loss of function variants. We didn't find any specific hotspots. Variants were spreading all over the protein, and the only exception could be this one, the tetralogy of Fallot, which is found in a prevalently described case by Morton et al. And in one case in our cohort. And they are in the mutation are in exon 14 and 15, which are part of C-terminal domain, which is very important for transactive functions of beta-catenin. So pulmonary valve involvement is reported both as valve stenosis and absent pulmonary valve. And pulmonary valve stenosis is prevalent in this syndrome, the Noonan syndrome. We try to do some connection with other already clear syndromes. And for example, tetralogy of Fallot and absent pulmonary valve are also reported in 22q11.2 deletion syndrome, which is characterized by this specific clinical features. And about this, I would like to say one more thing, which is that beta-catenin deficiency in mice was shown to cause phenotype resembling the velocardiofacial syndrome. So mice with inactivation on beta-catenin caused abnormalities in the DiGeorge phenotyping spectrum mouse model, including malformation of the great vessels, hypoplastic and pulmonary aortic arteries, and also characteristics of the face, like micrognosia. So we decided to look for connections in the literature with, for example, NKX25 transcription factor and GATA4, which are important heart protein modulator. Is especially NKX2.5 is a transcription factor essential for the outflow tract and right ventricle development, exactly where also beta-catenin is very active. And NKX25 is also important in the second heart field metabolism, DNA metabolism and proliferation. So we looked for the literature and found that it is supposed that NKX25 negatively regulates CTNNB1 and positively regulate GATA4 in cardiomyocytes. And probably NKX25 modulation of these two transcriptional factors is important in heart development. So is it possible? Of course, we need more evidence. This is only one evidence in literature that there is a link between NKX25 and GATA4 genes in the connection with beta-catenin. About atrioventricular canal, it is especially expressed as a cardiac defect in these four entities, clinical entities. And we have to say that, as I said before, that absent pulmonary valve with intact ventricular septum, a patent doctoratoioso is very rare. It has been just previously reported in one genomic disorder, and now in this case of CTNNB1 syndrome. So we think that CTNNB1 syndrome can be included in these syndromes associated with the trilogy of Fallot, pulmonary valve stenosis, and absent pulmonary valve. So this is just to end my talk, to say that we really think that it's important to focus on the cardiac phenotype in the first time you approach a child with CTNNB1 syndrome, but also in the management of the heart, because few very small heart defects can get severe during time, just as mitral valve prolapse. And it was nice to have many comments after the publication of our papers from the net, and so we have this comment testify that cardiac artifacts in CTNNB1 syndrome are actually present. We don't have clear numbers yet, but we are on a way trying to understand the involvement of beta-catenin in human heart formation. Thank you very much for your attention.